What is going on, guys? Crazy long day today. I literally just got home and slammed down some food. I didn't really have lunch or breakfast, but it's all good. It was a good day. A lot of really good cases today. Just got done at the very end. Just a ton of line. Had to put a chest tube in. Somebody basically infected. Pleural effusion. So it was a good day all in all. But I managed to get you guys some case of the day action too, right? So the case of the day was kind of unique. I wanted to tailor it to IR. I wanted to tailor it to procedures because that's what I was covering today. So I wanted to do something procedural related. Were you guys familiar with what you were even looking at to begin with? Because again, we talked about a little DSA imaging before, I think maybe last week, and kind of what a DSA image is and why it looks a little weird and why a lot of people are not used to seeing what a DSA image is. So that's kind of what we have on today's question of the day, or case of the day, I should say. It was a DSA image, and I asked you, well, the second one was, and the first one was kind of like a little run of what we were even trying to do. So this is pretty classic of when we're in the arterial system and we're trying to select one of the main branches off of the aorta. And then I have to ask you guys, so what are the main branches off of the aorta? And you guys should immediately come back with celiac first. Then it's going to go SMA. You're going to have some renals in there as well, and then IMA. So the main ones, when we're talking about GI bleeds, we're talking about cancer therapy for the liver, we're talking about, I don't know what else we're talking about, but those are the main ones. You want to evaluate your celiac, your SMA, and your IMA. They all go to different things, so you need to figure out, okay, well, if I have, I don't know, something happening in the liver, if there's a liver issue, if there is a liver trauma, if there's a splenic trauma, what am I immediately going to go to? I'm going to go to the celiac. If I have an issue with the sigmoid colon, I think the patient's bleeding out from there, they got a tagged RBC scan, looks like it's positive for the sigmoid colon, I'm going to immediately start interrogating the IMA. So you really need to know anatomically what is being supplied by the different vessels, vasculature. So then I'm going to ask you, so what are the main branches off of the celiac? And you need to remember the three main branches that come off this celiac. Splenic is one, left gastric another one, and then common hepatic. And then you may wonder, there's different, you may get confused, like the hepatics, right? Because there's a lot of different names for the hepatics. There's a right and left lobe, there's a common hepatic, there's a proper hepatic, so you may get a little confused as to which one's which. So splenic is pretty self-explanatory, right? The artery, and once again, for people who are joining, I'm talking about the celiac trunk right now, or the celiac axis, the celiac, right? So splenic is self-explanatory. It's going to go to the spleen. The left gastric will go to a portion of the stomach. Don't worry about too much what portion right now. And then there's the common hepatic that comes off of it, okay? The common hepatic will turn into the proper hepatic. And you have to figure out at what point does the common hepatic turn into the proper hepatic. And that's when the gastroduodenal artery comes off. And that's the question that I ask you guys. What is this right here? This is the gastroduodenal artery right here. Let me stretch over here. So this is our catheter. We're in the aorta, okay? And then you got the splenic here, you got the left gastric here, and then you got the common hepatic over here. And then the gastroduodenal artery, let's just shorten it up and let's act cool, right? Let's call it the GDA. So the GDA is coming off here. And then right after the GDA, then I'm gonna start talking about the proper hepatic. It's kind of confusing at first, and in my way of remembering this is you have to be a commoner. Just think like old times, right? Medieval times or whatever. You have to be a commoner before you become proper, right? That's the way I think about it. It's stuck in my head. I will never forget it now. So common hepatic, then the GDA comes off, then it becomes the proper hepatic, okay? And then you have the right and left hepatic arteries that come off of there. So it's very important when you have cancer therapy. There's different types of cancer therapy that an interventional radiologist can do. TACE is one, transarterial chemoembolization, which is catheter-directed chemoembolization. Number two, what we use is Y90. This is radiation beads. So we can inject radiation, and it's catheter-directed, and it's directed right at the tumor itself in the liver. So those are the two main ones. We can do a lot of other different types of embolization. You may hear the word bland embolization, which is basically no fancy chemo or anything like that, radiation. It's just some embolization stuff that will go in and just plug up the artery, and it's just, that's it. There's no secondary stuff that's going to happen. It's just straight mechanical. It'll plug it up and stop the vasculature from going to wherever you need to. What else do I want to talk about? I want to talk about how my initial question was, am I in the arteries or in the veins, right? And how do you know if it's arterial or if it's venous? We've talked about it many, many, many times before. This is going to be flipped in the screen, but this is my right IJ right here. I know it's going to be flipped, so I don't know, however you want to do it, but this is my right IJ right here. This goes down into SVC, goes to the heart, and then it goes into the IVC. So that whole side is my venous side right here. This is all venous on this side. And so then the other side will be all arterial. So then when we look at this image here, you can see which side of the spine I'm on. You may say, oh, well, it looks like it's midline, but look, I axised over here, and then it's coming, and then it's eventually coming over to that side. If it's for venous, it would legit just be like right here, and it would be all along the left spine right here. So this is how I knew I was in the aorta, okay? You can kind of see, I tried to window it a little, you can kind of see an artery right here lit up. It actually comes up pretty well in the video that I sent you guys. It's very faint because that was the initial injection. We just kind of puffed some contrast in there just to make sure that we're kind of in the right vicinity. And then once I hook the celiac or the SMA, whatever, with the catheter, then we'll do a power injection, where it's basically you hook it up to a machine and it just blasts the artery full of contrast, and it takes a bunch of fancy images. So real quick recap, this was the arterial system. How did we know? I told you about the spine, the positioning. Anytime you see catheters like this, there are times when you see it in the vein, but usually when you have catheters in the vein, they don't have these weird little curves like that, usually, okay? What else is important about this case? What else? Somebody else. Who's got some questions? Before I figure out, then the first artery that lit up on that video that I gave you guys was the SMA. So if you ever look at a CT scan, and I highly suggest that you do this, look at the CT scan, pull up the sagittal image, okay? And if you're having issues with, what's sagittal image, hey, that's what I'm here for, right? So axial image, you cut the patient like this. Coronal image, you cut the patient like this. Sagittal image, you cut the patient like this. Coronal, I don't know how you want to remember it. They wear the crown like this, something like that, right? Axial, you go along the axes of the heart, the liver, something like that, or transverse, however you want to remember that. So then sagittal is like this. So I highly suggest you go to a CT scan that's contrast enhanced, look at the sagittal image, go to the aorta, it'll be nice and linear, and then you'll see how the SMA comes off. The SMA, so imagine this is the aorta right here, this is the feet of the patient, obviously, and there's a head's up here, so the aorta's like this, and the SMA literally comes off like this. So it does, so again, here's the aorta, and then it literally does one of these. That's why, I'm about to go on a tangent right now, that's why you get SMA syndrome. Again, if this is the aorta, this is the SMA. SMA syndrome is where this angle is too acute. So there's not a lot of room between the SMA and the aorta. And guess what goes through there? If somebody can shout that out, what is SMA syndrome? What actually courses through the SMA and the aorta that gets pinched off to cause SMA syndrome? So that's how you'll know what the SMA looks like. It looks the exact same on angiography, on ultrasound, on CT, on MRI. That's exactly what it is, okay? What else? Somebody mentioned renal vein. I want to be very, very clear that this is a commonly confused topic between nutcracker syndrome and SMA syndrome. That's why I actually like to talk about this and bring this up whenever I do any sort of talk. I'm going to let you guys go and look this up because we're going to have a whole discussion on this one day between SMA syndrome and nutcracker syndrome. Completely different entities, and they're highly confused, just like thoracic outlet syndrome and SVC syndrome are highly interchangeable. They're incorrectly interchangeable, but they are confused. A lot of people use them when they shouldn't be using either or. Those are two things that I want to have a whole session on. I'm going to have all this I'm going to have all this fancy imaging for you guys, and we'll go over it at one point, but go look that up. SMA syndrome is different than nutcracker syndrome. Remember that. So we went over this. I want to go real quick for arterial axis because we're talking about the arteries here. Arterial axis, we briefly talked about this before too. There's different ways of doing it. One, you can use ultrasound and stick it under ultrasound. Number two, which I like to do, is I use direct palpation. I feel the femoral artery under my fingertips and I leave a little bit of gap. So I'll feel the artery here and then I'll feel the artery here. So they're far apart like this, and I stick in right in between. Because if I know the artery is coursing between this fingertip and this fingertip, well then it's sure as hell gonna be coursing between them as well. So then I stick right in between. Here's another question that I want you guys to ponder. What are you supposed to, so you want to stick the femoral artery, okay? What landmark is underneath where you want to stick because you want to be able to hold pressure? And I'm asking this in a very unique way and weird way. Why do you not want to stick higher? Okay, the answer is femoral head, but let's go to the secondary question because that's even more important. Screw the primary question. The femoral head, you want to stick on top of the femoral head, preferably the inferior third or the lower third of the femoral head, okay? What happens if you stuck higher? What kind of complication can happen? And what happens if you stuck lower? What kind of complications can happen? This is highly important, not just for the person or the resident or the med student who wants to go into interventional radiology, into vascular surgery. This is extremely important for somebody who's taking care of a patient on the medicine floor as well, because you're gonna have patients come back from cath lab, from IR, from vascular, and you need to know what kind of complications you're dealing with, all right? So the answer for this, if you stick too high, you don't have the femoral head to hold pressure against. So then your artery's floating in the wind and you can't hold pressure at all. So what is that gonna cause? And this is, by the way, above the inguinal ligament. That can cause a retroperitoneal hematoma. So again, if you're a medicine resident and you have a patient who just came back from cath lab and his hemoglobin is dropping, you're trying to figure out why. The two things that you should be concerned about. One, you have a pseudoaneurysm that when they stuck with the needle to the femoral artery, it kind of lacerated the wall of the artery a little bit and it developed this pseudoaneurysm that may be bleeding into the thigh. Number two, if the hemoglobin drops a lot, be worried about a retroperitoneal hematoma. Okay, that's the thing that may happen if you stick too high above the inguinal ligament. What happens if you stick below the femoral head? Well, at the level of the femoral head, you all remember navel, right? Nerve, artery, vein, empty lymphatics, right? So you all remember navel in the femoral region, and that's where you want to figure out where to stick if it's an artery or vein, right? So navel is kind of nice when A and V are side by side. But when you go a little bit lower, A and V are not side by side anymore. They're actually front and back now. So if you stuck lower than the femoral head, you have a potential of causing an AV fistula. It's time for water. I literally have not drank all day. So you may get an AV fistula, okay? That's the two things that you need to worry about when you're getting arterial access. You guys are gonna be placing, when you're interns, residents, you're gonna be placing art lines in the groin every once in a while. Mainly you go into the wrist, but you will be doing it. You may do central lines blind on the floor when you have an acute status, like in a patient's coding or something. You may need to be placing stat central lines. You don't need ultrasound, don't do that. Navel, remember that. Get your fingertips, palpate the artery, and just stick medial to it. Whatever way medial is gonna be on the stupid screen, right? Stick medial to it and you'll find the vein. Just remember that. You can't do it under ultrasound, obviously, but you don't need to. What else? Can I answer any other questions about this case? Or can I go get dinner now? What did I miss up top? Scroll. Oh, boy. Future doc asked, did you ever struggle with math? And then somebody replied, that's a pretty random question. That is, man. I did. I don't know. No, I think I was fine. I went to calculus. I don't know. Math's not my thing. All right. And you guys had a nice conversation between yourselves. I like that. Duodenum. Somebody answered duodenum. Good. So somebody remembered now SMA syndrome, what it pinches off, so you can have a gastric outlet obstruction. All right, we good? Any other questions I can answer for you before I get out of here? I'm about to go on vacation tomorrow. I will keep up case of the day 100%. I'm going to try my best to get the lives in because I do this for you. I'm doing it right now. Yeah, I'm going to try, but I'm letting you guys know. All right, I appreciate you guys. We're going to do this again. As always, you're the best. Take it easy.